Well, bones, speaking of height, clearly bone health is something that is a new concept in neuromuscular medicine. Um, Individuals who don't bear weight, particularly who don't bear weight with some degree of vibration or pressure or things of the sort that occur naturally as kids bounce and jump and run, don't build the same mineral density. And that creates a whole new list of concerns with respect to comfort and well-being. How have you dealt with that with your team, Basil?
As you said, Nancy, the bone health has become very important during the last 10, 15 years in the entire field of neuromuscular diseases for the reasons you explained. And talking specifically about SMA, we routinely discuss the issue of vitamin D intake and calcium intake. Of course, most of the discussion is carried out by our nutritionist, but even the nutrition is not available, then I would discuss it with the family to make sure the child has adequate calcium intake and that the vitamin D levels somehow are monitored. So we do measure vitamin D levels in blood periodically, particularly during the winter and spring when you don't have a lot of sunshine, to see whether we have normal levels of vitamin D. In most laboratories, the cutoff value is 30. And if we have a value, let's say between 20 and 30, which is thought to be vitamin D insufficiency, then we recommend vitamin D3 supplementation, either which can be from 500 to as much as 2,000 international units per day. If the child has a value in the deficiency range below 20, we refer them to the bone health program, which we happen to have at our institution. Because many of these kids, they need DEXA scans and they require specific treatment of this vitamin D deficiency with high doses and so on. So that has become a routine part of our care in the SMA clinic. But as I said, it's really the nutritionist and the gastroenterologist who deal with that most of the time.
Mm-hmm. And I know that one of the issues that thin bones can make much more complicated is management and treatment of scoliosis. What have your colleagues in orthopedics added into this to help us out?
Sure. Orthopedics is a part of the multidisciplinary clinical care. So we routinely have an orthopedist in the SMA clinic who monitors and treats the orthopedic issues that arise in our patients. And as you said, scoliosis is a major one because many of our patients in the clinic, they have type 2 SMA, and of course some of them have type 3, and they're prone to developing scoliosis. And now with type 1 babies living longer because of the interventions, many of them will also require long-term orthopedic care. So it's not unusual to have x-rays taken on that day to monitor the degree of scoliosis over time. And as you know, there is conservative management which can be applied by using orthosis, body jackets, which are applied for different periods of time during the day. And at some point, the scoliosis, if it reaches a critical point, it may have to be corrected surgically. And it is something that the orthopedists decide how to deal with it. But I have noticed that many of the children, they have growing rods implanted. to stabilize the spine and prevent progression. And these rods, as you know, they have to be lengthened periodically. And it used to be done surgically from time to time, but now we have the so-called magic rods, which can be lengthened by using a magnet. And then when the child gets older and requires permanent fusion of the spine, that will be done by orthopedics to stabilize the spine long term.
And as we'll be talking about pretty quickly, some of the treatments for spinal muscular atrophy can involve intrathecal administration of medication. So the whole issue of presence or absence of scoliosis and what kind of treatment was used, whether it was a fixation as was done in the past, or whether it's a little bit more permissive growing rod, all of those can affect treatment of a spinal muscular atrophy over time.
Not only that, but the osteoporosis sometimes make it difficult to use fluoroscopy, and you have to use CT in order to access for treatment. But I just wanted to go back what Basil had said about SMN protein and its role outside of the central nervous system. And when you spoke about the gastrointestinal dysmotility issues and the dysautonomia that the babies have, that's oftentimes seen in type 1 that is likely related to the absence of systemic SMN protein. And I recently read an article where fractures and osteoporosis was equally present in type 1, type 2, and type 3s, raising the possibility that it's not just in mobility that contributes to the osteoporosis and fractures, but that there may be some systemic, at least some preclinical data show some osteoclastic activity of SMN protein as well.